Okay, you've heard the speech about the cards in the middle of the table. If you don't have any cards, somebody will give them to you. So I hope you get your questions ready and bring them up, and we'll start immediately. But apropos of the last comment that Steve made, I just say a couple of weeks ago I asked someone who's well known to all of you, though he only lives here part-time, George Halverson, if he could name one thing that he would do in order to bring down health costs most quickly. He said, oh, that's easy. He said, I'd insist that everybody in America fast walk 30 minutes a day. He said, now there's no disparities barrier to that. There's no social determinants of healthcare barriers to that. There's no beating up on fat people, that sort of thing. It's no get rid of the 32-ounce Pepsis or the Cokes. It's just fast walk 30 minutes a day. He said you can even split it 15 minutes in the morning, 15 minutes in the afternoon. So that's a thought to add to my dentist story. But let me start while the questions are coming up with what advice Rob and Steve might give to Dr. Nicholas. And I don't mean thinking specifically about what do you do with the little territory and the relatively small and those other problems, but given the way he was frank with us about the frustrations of running an orthopedic practice today, which is highly ranked in terms of quality and cost or value. I guess that translates into value. Do either of you, in light of what you said or your experiences, have some advice to give to people like Dr. Nicholas, we won't use it specifically?
Actually, he referred to it. I can't remember the exact phrase, and I couldn't see the slide. But as I remember, it was something about thinking fast, thinking outside the box. When I first got to Fairbault, I introduced a phrase on campus called disruptive innovation. Many of you may have heard of it. And there's been a fair amount of research and writing by a gentleman by the name of Clay Christensen on it. And so I told the staff we were going to go through disruptive innovation. It must be unsettling to change. Then I heard the recently retired state demographer, Tom Gillespie, use a phrase that's a little bit more bold, creative destruction. And what I said to the staff is we need to, in a creative manner, dismantle the past. And I think hospitals have a tendency to sit on their laurels and kind of go with the structure as it's been. Recently, I read an article in one of the medical journals. I can't remember which one it was, and it caught my eye, and I'm now carrying it with me as I talk actually to physician practices on campus. And don't mean this is a threat, but it's simply entitled "Change or Die." And what we're talking about is the burning platform. So you referred to that. It's, I think, being nimble and fast is the tricky part.
Well, I would answer that actually with an experience, and Dr. Meyer's already indicated that he gets it, but let me just share it with the group. Oh, many years ago, I was asked by Mayo Clinic to go work in the Quad Cities with Deere and Company to work with their group to set up an employee independent health clinic that would be sponsored by Deere in the Quad Cities. And so you have to realize this is many years ago. What I'm talking about right now would cause sort of a yawn, and I imagine some of you are there. But back then, they decided that I was supposed to meet with the County Medical Society in Moline and have a conversation with them about what it meant to have Mayo Clinic working on some clinic management there. And gosh, you would have thought the Death Star was coming over the horizon that night. And yet, at the end of that meeting, after all the hue and cry and carrying on, I had two groups come up, one a specialty group and one a primary care group, and they said, you know, Rob, I guess Dr. Nesse would have known that, but they said, you know, Dr. Nesse, as we think about this, we already provide excellent care in this community. What can we do to be part of this program? How can we align ourselves with the program? Well, of course, that attitude and the reality of the fact that nobody wants to replace high quality, low cost providers in a market meant that they had opportunities for alignment. So this is what I'm saying about you don't need to be owned, but you do need to understand what it takes to be aligned for some sort of financial structure in reporting and practice analytics. And I think with that, you're going to see accountable care is actually, as mentioned, I think by Commissioner Jessup, it is a very, very iterative thing maybe define market by market. And I see a very nice future for Orthopedic and Fracture Clinic and for Dr. Meyer's Clinic, St. Croix, and others, because they're supplying a very specified service that is very hard to reproduce.
So Nick, you want to react to that, or just say thank you?
I think thank you would be good. I do want to just mention one thing. You know, along with thinking out of the box, you know, I've been involved over the last year and a half, and again, there's a little bit of disclosure that I have some financial and investment interest in the company, but I'm working on a product called Open Outcomes, and it's something that I hope that I and all of you will be very uncomfortable with, because the goal is to have patients track their results and those results be public and based on diagnosis, based on treatment. And so it's something that I think can really, again, put patients in the driver's seat and allow them to really be more involved in their care. And so I think we'll see if that adaptation is good or bad, but constantly trying to move forward.
Dick, there is a question here. What metrics do you use within your practice to measure and monitor low cost, high quality?
Well, most of those are measured externally, really. You know, Health Grades does most of that, so it's really not our own internal measurement. It's really how we're graded externally.
Let me ask you about one that, again, this is recalling a personal experience with a member of your profession who has a large orthopedic practice. And the way he responded to that, I remember asking him the similar kind of question. He said, you know, in any large practice like this, and the one that I'm familiar with, orthopedics, everybody knows who the 3 or 4 really best surgeons are in the whole group. And one of the things they know about them is that they don't always do surgery. They do really good analytics. And they have the capability to be a little smarter about diagnostics, you know, appropriate, and how do you get patients to do it, as well as the therapeutic alternatives and so forth. And I said, well, what's keeping the rest of them from being just like you? Don't they want to be? And he said, of course they want to be. And what's keeping them is a fee-for-service system and everything that goes with it. And so I said, what's the answer? And he said, well, some form of bundled payments. I mean, so that we can share in the savings that come from being the best in the bunch. So that there's a way to spread those savings around when alternatives are being used to the. So that was my little experience with that I will remember, because it relates to when you get to accountable care and you get to the bundling and you get to all the rest of the sort of stuff. It's sort of like part of the reaction. But Rob, this one's for you. The Mayo Clinic has been an outspoken advocate for accountable care. Why did Mayo Clinic decide not to participate in Medicare's ACO program?
Yes, and I was involved directly in that decision with Chief Administrative Officer of Mayo in a small group. The reasons for it actually had to do with our examination of the rules and regulations associated with the federal program. You all remember, perhaps all of you remember, in the spring of 2011 when the program came out, there was no attribution of patients. You didn't know who the patients were that you're supposed to care for, and they were going to base the payment on a combination of up to 65 measures, none of which were defined, and you really wouldn't know your performance till the beginning of the 3rd year, and you were at risk before you even knew your performance. An organization that signed up, I don't think they read it at that point. So we commented, and on the fall it came back much improved. There was better patient attribution. We still didn't know the rules. You had the opportunity for gain share the first 2 years, and then much more importantly, something called the Pioneer ACO came out. I think if you look pretty carefully, even at the groups here in the state and the Midwest that are part of the Pioneer ACO, they either have a captive insurance company or a very dominant insurer that they partner with that allows them to provide that coordination of care and practice analytics. Mayo Clinic works with, I believe, over 1,000 different insurers right now nationwide, and we made a very discreet decision that we were not going to split our operations in the Midwest and start playing off Mayo Clinic Health System against Mayo Clinic. That said, we are actively working to develop accountable care models, and we are looking for and finding at least glimmers of private insurers and others that we believe will set up private networks for accountable care, and we're anxious to participate.
Okay, next question. As far as delivery of quality and cost-effective health care as well as accessibility, how engaging are physicians and hospital organizations to the work of advanced practice professionals like physician assistants in meeting healthcare needs in a team approach for Minnesota and for healthcare reform? That's the question.
Maybe I'll start with that and then see where the others go. In each one of our sites, we have a very aggressive medical home program. We're concentrating that actually on folks with comorbid disease because these are the folks that, in my opinion, I think it was just said earlier, medicine is going to be a team sport. And Mayo Clinic is a very large provider, has a very large provider core of physicians, assistants, and nurse clinicians. We intend to expand that. We think that is a fundamental part of medical home practice going forward. We also support training of that.
I'll just comment. 2/3 of my professional career was in Air Force medicine, and I believe the military really leveraged all skill sets in the clinical setting, which then played nicely as I came out and first worked in Albert Lee and a physicians group in Wisconsin, Fairmont, and now Fairbault. All those practices were fully integrated relative to, again, the full range of skill sets and leveraging, whether it were maybe surgical PAs with the orthopedic side or the general surgeons or nurse practitioners on the primary care side. And witnessed an uptick in that kind of team approach. We all know the statistics on how many, before the ACA, we knew the statistics on lack of or shortage of physicians, and now we're seeing numbers that are kind of off the charts relative to lack of providers in total. And so that is definitely going to be something that's going to be essential, is to truly bring all the skill sets together and leverage everybody's talent.
And I think my perspective is from a smaller entity, really the whole pressure is almost purely financial, in that if we're being reimbursed less, we have to find ways for me to be available to do what I do, to potentially still provide care for patients, and we have to be able to bring physicians, assistants, nurse practitioners in to do the work that needs to be done, so that we can really still cover our overhead.
Here's a related question. How does the Accountable Care Act or affordable, whatever it is, and how does Minnesota propose to deal with the need to improve health professions education so as to meet the needs for primary care, care coordination, quality improvement, population health improvement, plus reduce the costs to students of medical education?
My answer is I have no idea.
Well, I'm another person that actually, I did not read 2,000 pages, but there was very nice 200-page summaries of that. Within the Affordable Care Act, there is a provision that, first of all, increases the availability of slots for primary care training, because some of you who are involved in education might know there are caps on slots, and the government supports a certain amount. The law says now that any caps available in any specialties may be assigned to primary care to allow more slots to be filled. That's the first. There's also provisions there was a provision in the bill to support higher payments for rural primary care, provision of primary care in rural areas. Unfortunately, and I had one more thing. CMS, as maybe you have read, is proposing a 7% increase in primary care fees and by a select group of primary care physicians, 3 to 5% for those who deliver primary care. Coming up in the CMS fee schedule. So those three things are there. I think in the end, though, you can put, this is kind of like private public, you can put all these things together, but if we go to pay for value and our profit centers become our cost centers, the practice of primary care will explode naturally, and these other things are just window dressing.
Okay, how does the Affordable Care Act or anything else support efforts underway in Minnesota to move away from impersonal, fragmented, reactionary, and distressing to patients, families, and caregivers end-of-life care?
Again, I'm certainly not an expert in that category here, but you know, in general, as we've discussed, you know, the whole idea is to be able to bring the coordination of care about. I think part, it sort of goes into my philosophy that I keep hammering upon of getting patients involved, families involved earlier to discuss these things. And so I don't know if there are provisions, I don't think there are provisions for additional reimbursement for counseling and discussion of end-of-life care, and that is a potential opportunity. But that really, you know, unfortunately, I've had the experience of losing my parents in the last 4 years. You know, most of them I have had that discussion earlier. But it's incredibly important to make informed decisions for individuals who are in, unfortunately, that situation to be able to make informed and smart decisions for their selves and for their families.
I think many in the room would know it. Perhaps the commissioner would know about long-term care, which I'm not as familiar with. But of course, support for that was in the original draft of the bill. A local congressperson labeled that death panel and it got taken out of the bill. So there you are. It's time for the medical profession perhaps to have a voice back in this and bring it forward as something separate that could be demagogued a bit less easily.
And I'll just offer a perspective from the smaller community. I mentioned briefly, one of the things we did was establish a department. It's about patient navigation. We're also doing that in our cancer center. We have a very, very sought-out hospice group that is part of our hospital service lines. But what is lacking is the coordination and the handoffs and so on. I would also submit that it's bigger, and I think Senator Durenberger has referred to this and others. There's a societal issue here. I'm distressed when I hear that I hear a helicopter coming in and it lands right outside my office window, and it may be the North Memorial, it may be Mayo 1, and I get a call then later from someone who is distressed because they shipped their 97-year-old grandmother to Rochester, and there was a feud in the family. Someone said, we must do everything. And of course, she goes to Rochester, and they may have kept her alive for 5 days. That's a bigger societal issue, but there is a lack of coordination. And for the practices in our setting, the more we can do together and have integrated care, then we increase the chances we can coordinate those activities as well.
And I don't know whether any of you are able to answer this one, but I don't know the answer. I'd answer it myself. What do we know about the $500 billion coming out of Medicare in the ACA? You know, this so-called savings. My impression is a lot of that was coming out of changes in Medicare Advantage payments for private health plans, not coming out of the hides of hospitals and doctors directly.
My understanding was the cut in Medicare Advantage plans from 7% plus to equal Medicare fee-for-service was the largest part of that. There was a cut, I believe, in certain payments for durable medical equipment under long-term services. I'm not aware of a huge effect directly hitting doctor fees. That's all I know about it.
So I think now's the time we should thank the Minnesota Medical Association, the Minnesota Hospital Association, Janice Silversmith in particular, this panel, and anybody else you'd like to thank tonight, because for bringing us all together. And I thought it was a very informative session. So thank you.